Okay, everyone, welcome back. This lecture, we are going to cover the management of diabetes, and after management, we are going to talk about the complications. So, as far as management is concerned, one thing is treatment and one thing is management. I'm talking about management. Managing diabetes, it's a chronic condition. So, what is needed for chronic condition is long-term management plan. Of course, it cannot be uh, cured, but it can be managed or it can be kept under control, you can say. Okay. So this is a condition which needs a multidisciplinary team, made up of endocrinologist, uh, and nowadays, there are diabetologists as well. So we need endocrinologist, we need uh, education, or the workers, the nurses who must educate the patients, even the doctors who educate the patients about the type, about what kind of disease it is and how they are going to live the rest of their life with this condition. We need podiatrists who take care of their feet. We need the help of ophthalmologists to get their eyes checked time by time. We need um, what you can say, the help of medical specialists who keep on checking their health and keep on monitoring them. Of course, we need a dietitian or nutritionist who manage or plan a diet for them. Okay. So of course, like there is a contribution of many type of experts to manage these patients. Okay. So of course, like it is like nutritional management with exercise, with monitoring, with pharmacological therapy and education. So these are the five components, okay, of diabetic management. Moving forward, the same thing: diet, exercise, management, and we have to keep on monitoring glucose level in the blood and urine. Okay, continuing these three things. So, what are the aim of treatment, or what are, like? Of course, it's a chronic condition, so we must define some targets or aims, which you can say which we must achieve over a certain period of time. So, as I was telling you, that HbA1c is reflects like the glycemic control or the control of blood glucose level over, we can say, 120 days. That's the normal lifespan of RBCs. Okay, so um, whenever the patients come, we if we want to check, for example, like the patients can do this thing, maybe they are not controlling their diet well, but the day they had an appointment, they want to go to the doctor. At that day, if they are taking some medication or if they are modifying their diet, so the results will be quite misleading in that case, simply. And what we will be getting is like a hypo, like a normal glucose level, but in reality, like, we don't know how much the glucose level, like, before 2 days, 3 days, 4 days. So that's one of the way thing, to understand here is HbA1c is the best way to, you can say, check the glycemic control. Okay, of course, over last 3 months or 120 days. Okay, so we use this thing for this for monitoring. Okay, so what is given that one of the target to control this condition is, like, we must keep the HbA1c level of these patients either equal to, or you can say less than, okay, less than 7.0%. Okay, so this is one of the target we have to achieve. Okay, uh, like keeping the glucose level below that. Okay, and once once we are going to keep this, the level of glucose less than this, it is going to avoid many of the micro as well as macrovascular complications. I will talk about them in a while, what is micro and what is macrovascular complications. uh, Anyone, for example, who have type 2 diabetes mellitus, and for example, the patient is younger, like young patient means like they have a long life expectancy. For example, someone who is diagnosed with diabetes at 60 years of age, or with someone who is diagnosed with diabetes mellitus at 30 or 40 years of age. Of course, the one with 40 years of age have a lot longer life expectancy. So in that one, we try to keep their level, HbA1c level, even less than 7.0, like basically less than 6.5. Okay, to further like reduce any complications in these patients. So okay, for example, if someone is old, because when we try to control the glucose level in a very precise way, or to the lowest levels possible, one of the risk is what, like when you decrease the sugar, basically the patients can go into hypoglycemia, which is quite dangerous as well, because hypoglycemia, our neurons, our brain cells can only consume glucose uh, for their activity. And what can happen is, once the glucose level is like less than, or like when the patient will develop hypoglycemia, they basically collapse. And when they collapse, okay, of course, like they must need some urgent attention. Otherwise, the people can die even while going hypoglycemia. So hypoglycemia can be a very serious short-term complication of using insulin, for example. Okay, so like in old age people, or when the life expectancy is not too much, then it's fine to even maintain the HbA1c level, for example, to higher levels. Like for example, I can say like 7.1 to 8.5. Okay, like this is like I'm talking about the American guidelines, guys. So like only those in which like there is limited life expectancy. Okay, of course, like these are the people who have multiple comorbidities, like coronary artery diseases, many other conditions, which can basically can increase their mortality simply. Okay, so now. Okay, maintaining HbA1c less than 6 is never recommended. Why? Because that is related with more, you can say, risk of hypoglycemia. That's it. So basically causing more harm. Now, one of the target is this one, very important target we have to achieve. Okay, and one of the target is to uh, you can say control the lipid levels as well. Okay, because one of the complication of diabetes is like coronary artery condition. So in high risk patient, for example, someone who is more than 40 years of age, especially, okay, 40 years of age, or someone whose diabetes, uh, like either this one or someone uh, having diabetes, you can say, for more than 30 years. Okay, so these are the people, um, uh, sorry, this was 15 years, more than 30 years of age, and diabetes for more than 15 years. Okay, so we have to control the lipid levels as well. And one of the target is to keep the blood pressure, especially less than 130 by 80 millimeter of mercury. Okay, like you would understand like why I'm talking about these two things when you will study the complications. Okay, so that like at that stage you are going to understand this thing better. So now what are the things we have to treat this condition? Like we have to reduce the insulin resistance, we have to augment or increase the insulin secretion, we have to reduce the gluconeogenesis, and we have to treat the effects of lipolysis. And like if you know like all the functions of insulin, you will know like why lipolysis is there. So glycemic recommendations, guys, I talk about like the blood pressure and the lipid cholesterol level I was talking about, it's written over here. So how we approach the patient, of course, like now we are talking about like the patient who is already diagnosed with diabetes mellitus. Of course, it could be either through screening, it could be either through sign and symptoms, or it could be like any XYZ, like someone who presented with any complications of diabetes. So whatever is there. So I always say that, always discuss the, what you can say, treatment under three, four headings. Like the first heading is always the conservative management, like the things which doesn't require any medication, but rather you can uh, bring some change in their life. Okay, like someone is smoking, you can ask them to quit smoking. It's a big change. So uh, there are certain things which we can do in these patients as well. So first of all, we will try that. Then, of course, we will go for pharmacological treatment, and the last one, of course, uh, like the other treatment, like surgical treatment. So non-pharmacological treatment is also known as conservative treatment, and then pharmacological treatment, and then surgical treatment. Okay. So before going on this, I would like to talk about the what lifestyle or conservative management, or what lifestyle modifications you must bring in the patients of diabetes to control the diabetes, to decrease the risk of the complications, okay, and to improve their life expectancy. Okay, so first of all, we make a diet plan for them, diet change, of course, like diabetes patients, they must change their diet, and daily carbohydrate intake should be around 45 to 60%, proteins around 15 to 20%, and fats less than 35% of their daily intake. Okay, so we ask them to limit the intake of their saturated fats, okay, to less than 7%, and as well as the polyunsaturated fatty acids should be less than 10%. I'm talking about out of the daily calorie intake. Okay, we ask them to limit salt intake. Simply say them no table salt. We ask them to limit alcohol. We ask them to limit smoking, and we ask them to limit even caffeine intake. Okay, and one of the way to remember these things is SNAP, SNAP. S is for smoking, N is for nutrition, A is for alcohol, and P is for physical activity. So we ask them to um, uh, start daily physical activity, increase their regular physical exercise. Okay, I will tell you like what is the guideline is. It's basically exercise have a very good effect on the health. Like even healthy people should do exercise every day. It increases the microcirculation in your body. It improves the insulin sensitivity. When you're exercising, your cells don't need insulin for the glucose to enter into the cells. It controls the lipid levels. It controls the blood pressure. It help in reducing the weight. So a lot of things are there. What you can say, um, which exercise can bring in your life. Okay, so smoking cessation, regular physical exercise, all these things, we ask them to bring their weight in ideal limits, okay, or you can say the BMI should be in normal limits, okay. Like try to bring it, of course not so hard. So of course, for that, we refer them to our dietitian, and the dietitian decide like what to do, what's best for them. Either they can define some diet plan, they can tell some exercises, and uh, weight lose should be always, you can say, in a very controlled way. Losing too much weight like too quickly is also not good for health. So that's what is required in this case. So exercise, how much exercise we should do? See, at least 3 times per week, and they like what WHO says, enough to produce some sweat on your body. Okay, but one of the ways, what, 60 to 80% of maximal heart rate. What is this one? To know your maximal heart rate, it's like there is a way to calculate that. It's basically in this way, like we subtract the age from 220, so that's the maximum heart rate you can attain. Okay, so at least 3 times per week. At least you can see a mnemonic over here, fit, at least 3 times per week. At least it should be aerobic exercise, and at least it should produce some sweat on your body. Okay, so this thing. So of course, like we educate the patient what is the condition, how we can control that, and things like this. So now, actually this slide is so extensive, guys. So I don't want to put in you in details of the slide. Okay, it's like too much extensive. Okay, now comes the medical treatment. Okay, one more recommendation, guys. Whenever we diagnose anyone, it's a very important point. Whenever we diagnose anyone with diabetes, we don't put them on uh, medications directly. We at least try 3 to 6 months of lifestyle modification. Okay, that's very, very, very important. Okay, whenever anyone uh, is diagnosed with diabetes, we don't directly put them on medication. We ask them to change their lifestyle for at least 3 months. Okay, if in 3 months they can control good glycemic control, it means they don't need any medications. But if in 3 months they cannot control their glycemic control, then of course we put them on medications. Okay, now talking about the medications, if it is type 1 diabetes mellitus, then the only treatment is insulin. When there is no insulin, you have to give them insulin. If it is type 2 diabetes mellitus, we have a lot of options. We don't start with insulin, but we have a lot of other drugs. You can see over here, type 2 diabetes mellitus. This is the major effect, like the smaller is minor effect. So see, there's a lot of drugs like, bicarbonate is there, thiazolidinones are there, sulfonylurea and meglinotides are there, and thiazolidinones are there, alpha glucoside inhibitors are there. We are going to discuss. Okay, insulin, of course. Anyone who have type 1 diabetes, insulin is the only treatment. Anyone who have type 2 diabetes mellitus, we treat them with other drugs, and later on we put them on insulin. Okay, so what is that? Sorry, like don't have to open this one right now. Wait, these are the exercise benefits. Sorry, wait. Okay, so let's talk about the treatment, pharmacological treatment of diabetes mellitus. Okay. Now, you can say pharmacological treatment of DM2, diabetes mellitus 2, of course, like not diabetes mellitus 1, cannot, only insulin. Okay, No other pharmacological other than insulin is tried in type 2, sorry, type 1. So, first of all, what you did, you try 3 months of lifestyle modifications. For example, if the patient have increased weight, you ask them to lose weight. If they are smoking, quit smoking. If they you drink too much alcohol, quit alcohol. If they are having bad dietary habits, control that. You ask them to do physical exercise. Once you have done all these things and you found that the glycemic control is not reached, okay, then what you have to do, you have to start initiate the drug treatment. Okay. One of the guidelines says, for example, if HbA1c is greater than 8.5%, okay, at the time of diagnosis, um, directly start treatment right away, okay, because 8 point greater than 8.5 is too high. And what we give them is we give them with metformin, okay, metformin. So what is this metformin? Um, like remember this thing, like my language, like M is for mota, right? So we give metformin in fat people, okay, or what does metformin do? Like it increases, what you can say, it decreases the resistance of insulin in the peripheral tissues, and that's why, like, it improves the insulin action on the cells, okay. um, so either we can give metformin if we found the results in the patient, that's fine. Otherwise, we combine metformin with other drugs, or we can start insulin, for example, if it is like too much high, okay. What are the drugs which we can use, what you can say, for the patients of diabetes mellitus? There are many. Okay. So talking about the drugs, I will give you the names. I will talk about few side effects. Of course, I'm not teaching pharmacology right now, but I will talk a little about the drugs. Okay, but not too much time we are going to waste on that. So metformin is basically, it belongs from a drug class called as bigonite. Okay, so it increases, as I told you, it increases the insulin action in the peripheral tissue. Okay, so that's why, that, like, this one is good in the people who are, like, whose weight is too much. Um, like in my country, in many other countries I have been to, it comes by the name of glucophage. It's not the only name. There are many marketed products, it gives, but glucophage is very, very, very commonly available all over the world. Okay, so especially this metformin is given in type 2 diabetes mellitus when the patient have increased BMI. Okay, and it causes a little GIT side effect, like GIT upset. Okay, and the good thing about this drug, metformin, is what, um, it is weight neutral drug. Okay, when we put patients on this drug, they don't lose weight, they don't gain weight. Okay, because most of these people, they're already fat. Metformin. Okay, the second group, which is preferred drug in, especially, you can say, slim people. As for slim, remember, as for sulfo uh, sulfonylurea, sulfonylurea drug. Okay, so sulfonylurea, as for slim, as for sulfonylurea, what is the function of this drug? Very interesting. It increases the beta cells release of insulin. So simply, it basically let the beta cells to produce more and more insulin. So one of the brand name I remember about for this drug is called as Diamicron. Again, much of the world, this drug is marketed with this name, Diamicron. Okay, so There are many drugs which come under this group. Some are sulfonylurea, some are non-sulfonylureas. For example, this is like the class of this drug is called as, that they are collectively called as insulin secretagogues. So there are sulfonylureas, and there is, you can say, non sulfonylureas as well. So many drugs are there. In sulfonylurea there is glyclazide. Glyclazide is the one which diamicron have. Glympyride is there. In non-sulfonylurea group there is repaglinide, there is neticlinide. Okay, so if I will give you one example of this thing. For example, sulfonylurea, one of the example. I'm not writing the marketing name, but I'm writing the chemical generic name, glyclazide. Okay, and non-sulfonylurea, one drug, if I will write the name, is called as um, repaglinide. Okay, so these are the drugs. So okay, all these both groups, they causes some liver, like their side effect or contraindication is like we should not give anyone who have some liver abnormalities. Okay, now see, this one we give in fat people, this one we give as for slim, as for sulfonylurea. So remember guys, one of the side effect of this drug is, these drugs is weight gain. Okay, one of the side effect of these drugs is weight gain when we put them on this thing. And one very important point, and I love to ask that thing in MCQs, is what this one doesn't increase the release of insulin. So metformin never causes hypoglycemia, but this one increases the release of insulin. So sulfonylureas, one of the side effect is hypoglycemia. Okay, one of the side effect of sulfonylureas is hypoglycemia. Okay, other than these drugs, there are many other drugs. Okay, many other drugs are there. Just give me, I will increase this. Okay, so there are many other drugs, you can say, which are there. um, One group is called as, like which I was showing you over there, that is called as thiazole thiazolidine dione. Okay, so these are collectively called as insulin sensitizers. Okay, so again, like when they are just insulin sensitizers, so simply they cannot cause hypoglycemia. Like they increase the peripheral effect of insulin, simply you can say. The name, one of the name I will tell you, very easy to remember, rosiglitazone. Okay, rosiglitazone. There is pioglitazone, drugs like this. So rosiglitazone, pioglitazone, we can give to the patients. Okay, of course, like this one again cannot cause hypoglycemia. Sulfonylureas can cause hypoglycemia. But we, like, one of the side effect, sorry, contraindication I remember about this drug is we should not give these drug to anyone who have congestive heart failure, because what it can do is like, it is going to cause more and more water retention and can make the condition bad. Then there is alpha glucosidase inhibitors. Okay, and now what are these drugs? One of the name of the drug, very easy to remember, acarbose. Okay, and now this is a very interesting group of drugs, because um, it don't have any systemic effect, but what it does, basically, this is a enzyme. Okay, this one, this is drug which inhibit an enzyme called as alpha glucosidase. So when this enzyme is not there in the GIT, basically the GIT cannot absorb carbohydrates. Okay, so that's very nice thing about this drug, like that simply whatever you will eat, the carbohydrates will, you can say, will not be absorbed from the GIT. But one of the side effect of this drug is what? Because the carbohydrates cannot absorb from the GIT, so they will be staying in your GIT, and the person will be having, bloating, flatulence, abdominal cramping, diarrhea, things like this. Okay. Now there are some new drugs. One thing is called as DPP4, Roman 4 inhibitors. Okay. Now, what is DPP4? It is dipeptidyl peptidase. Dipeptidyl peptidase inhibitors. So, what is this dipeptidyl peptidase inhibitors? They inhibit the degradation of, like, there is something, a hormone called as incretin. Okay, inside the body there is a hormone called as incretin. 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 So this hormone incretin basically stimulate the insulin secretion. Okay, the incretin hormone stimulate the insulin secretion. So what these drugs do is basically they inhibit the degradation of anti-incretin hormones, like the hormones which degrade these drugs, they inhibit those things. So when this one will not be degraded, so this one will increase the insulin secretion as well. Now, because the okay, and what is the names of this drug? I'm removing this incretin because I'm writing the one name of the drugs. There are many gliptan. Okay, so one thing is sitagliptan. There are many saxagliptan, linagliptan, many other drugs are there. So, like, this is a group which we use in the treatment of diabetes. Of course, like, there are many guidelines when to use this, when to use that, and things like this, but I don't think so, like, you need them at this stage. Then there is glucagon like peptide analogs. Okay, analogs. So glucagon like peptides analog. So what basically these glucagon like peptide analog do, they basically bind to GLP 1 receptor, and that's why they are also called as glucagon like peptide 1 receptor analogs. So what it does, like, it bind to the GLP 1 receptors, and simply they promote insulin release. And when they promote insulin release, guys, the side effect can be hypoglycemia. Okay, so exenatide is the name of drug. Exenatide. Okay, this, and there is one more group called as SGLT2 inhibitors. Now, what is this one? SGLT is basically sodium glucose linked transporter 2 inhibitors. They enhance the urinary glucose excretion simply. Okay, so these drugs, they don't allow the kidney to absorb back the glucose, so all the glucose which will enter in the body, they will be excreted. Now, one of the name of this drug is, which you can remember, is dapagliflozin. Okay, anyhow, like, these are the few of the drugs, which are used. Okay, this drug, of course, because it affects on the kidney, we cannot give to anyone who have kidney failure, or anyone who have end stage renal disease, anyone who is on dialysis, we cannot give them to this thing. Now, this drug, because it increases the glucose, it stop the glucose, you can say, absorption from the kidneys. So, guys, one of the important thing to remember here is what there will be more and more glucose in the urine, and when the glucose level in the urine will be more, what is going to happen? there will be increased chances of more UTIs. So that is the side effect of this drug. Anyhow, you can see in your pharma books, what are the side effect of these drugs, because I think that's already too much. We talk about what you can say about these drugs, right? So these are the drugs we used for the treatment of diabetes, okay? And of course, once anyone have type 1 diabetes mellitus, or these things cannot be used in any patient, then what we can do, we can put the patient on insulin, okay? Now insulin is a big discussion. Of course, I'll talk about few things about insulin, of course, okay, but I will not go in too much detail of insulin. So for example, what is insulin? Insulin, we start, it comes in injection form, and it is the same hormone which we give to anyone who don't have insulin. For example, type 1 diabetes mellitus or type 2 diabetes mellitus, which cannot be controlled by simple drugs. So of course, we educate them, how to use insulin. We tell them how to take injections. There is an insulin syringe. Nowadays, there are sophisticated devices like pumps are also available. We tell them, these are the places where you can give your insulin injection, the lateral of the thigh or the and we keep on telling them that keep on changing the position of the injection, because they have to take every day the injections. So you can give them by subcutaneous injections, and nowadays, as I told you, there are pumps are available which are continuous, which can deliver the drug continuously in the body. Okay, these are newer things, which are available, of course, to deliver like insulin, because the insulin is needed, you can say, on everyday basis. Okay, so we can give them IV infusion as well, but just in emergencies. Okay, so now the insulins are different type of insulins are available, guys. There is short acting, okay. There is short acting is also called as insulin regular, okay. And then there is what you can say rapidly acting. It is also called as insulin aspart or insulin lispro. Then there is, okay, these are also called as bolus insulins. Then there is basal insulins, which are basically long acting or intermediate acting insulins. I'll see if it is written over here. Otherwise, I can write them down. This is the name of the same drugs which I talk about. Explanation of the drugs, guys. Okay. Anyhow, I think instead of wasting time, we can talk about that here. Okay. So insulin. Okay. Now insulins are available in different forms nowadays. Okay. They can be coming forward. Okay. There are bolus insulins. Okay. And there is basal insulins. Now in bolus insulins, there is short acting, simply, which start their action in seconds. It comes by the name of insulin regular. Okay. There is rapid acting as well. The action is too quick. It comes by the name of many other names are also there, guys. I'm just writing one. You can remember insulin aspart, okay? Because I'm making it simple for you guys as well. Anyone who is listening to this, of course. And then there is basal insulins, of course. They are intermediate acting, okay, and you can remember one name that is called as NPH, and then there is long acting, which is called as insulin detrimer. Okay. Now, like, see, short acting and basal ones are long acting or intermediate acting. Now, like in the market, what is available nowadays, the good thing is all these things come in combination form, pre-mixed combination form. Okay. Like, and how we start insulin? Very easy way to remember. This is the most easiest thing you can, like, which will help you a lot. How much insulin is required? Basically, we start, or the estimated total daily insulin requirement is around 0.5 to 0.7 units per kg. Okay. This is the daily requirement, but it is not like how we start. We start by giving, you could say, 0.3 to 0.5. So, for example, if a person is like 70 kilograms, okay, so it means like they need, like, in the start, we are going to start them with around 25 units per day. But then we'll increase their dose to somewhere between 35 to 40 units per kilogram per day. Okay. So, like this way, we are going to start them. Okay, so talking more about that one, the rapidly acting one, as like once the patient take the injection, it start acting within 10 to 15 minutes, and the peak reach in the blood around 1 to 1.5 hours, and after 3 to 5 hours, the effect is gone. Whereas the basal insulins, like this NPH one, once the patient is going to take that, it will take 1 to 3 hours to start action. It will achieve the peak in 5 to 8 hours, and it will stay in the body up to 18 hours. Okay. Some of the insulin, for example, the this long acting, like Detamir, they can work up to 24 hours, for example, in the body. Simply, guys, as I told you, premix are available in the market. Okay, nowadays that they have solved the problem. For example, there is one insulin comes called as Humulin 3070. Humulin 3070. So what is this one? Or there are many others. Okay, I'm just giving example of one. Humalog Mix 25 is also there. Humulin 3070 is also there. So this one is a pre-mixed insulin. Okay, what they do is, like, they mix up, like this one, which I'm talking about. This one, Humulin, is basically a mixture of this one, okay, with this one. Okay, so 30% they put this one, and 70% they put this one. So there are different combinations they use. Okay, and how I already told you, in type 2 diabetes mellitus, first you will start. In type 1 diabetes mellitus, you will start directly with insulin. Type 2 diabetes mellitus, you will start with lifestyle modifications. If the lifestyle modifications are not working, then you will start with, you can say, with starting drugs. And then if the drugs cannot maintain the glucose level, then of course we will go directly for what? We will go directly for what you can say, this insulin. So, of course, like you start with what you can say, less amount, and then we go for like big amounts. So, like in type 1 diabetes mellitus, what they do is, they, like, if you want to, like, no one is going to ask you, at this level, but if you see over here, there is like 1 dose program, 2 dose program, 3 dose program, 4 dose program. Like in this one, you have to take just 1 dose every day. See, like this one is, breakfast, this is lunch, this is supper, this is, bedtime, and this is midnight. So you are taking 1 injection, of NPH, which is the long acting one, and it is acting all the day. 2 dose program is like you have to take 2 injections. Okay, this one is like regular and spread mix, intermediate. Okay, this one is a 3 dose program in which you have to take 3 injections. This is a 4 dose program in which you have to take the 4 injections. Okay, and guys, like, it's very important to mention here, like, taking injections every day It's not an easy job. Like many times the people forget, many times they travel, they don't know, sometimes their insulin run out and they have to buy. So many problems arises because it's like a lifelong problem. Okay, so in type 1 diabetes mellitus, 40% is given as basal insulin at bedtime, and 20% is given as bolus insulin before breakfast. One of a good way, you can say, I'm talking about this regime. Okay, uh, like this is like one of the way, and sometimes we put them on metformin as well, because metformin increase the insulin action in the peripheral tissue. So this thing, if you're using some pre-meds, you can give in a two-dose regime. Simply take the two-third of the dose before breakfast. That is going to act, and one-third of the dose pre-meds insulin before dinner. Okay, this one. Okay, so of course, like you are taking basically two injections, so that's a good regime. So this one and this one, both are good regime. This one is a good regime for, you can say, if someone is want to take like four injection regime. If someone is want to take two injection regime, this is a nice one. Okay, so what we do, by the way, that they keep on monitoring the patient. Okay, nowadays, glucometers are available at home. So what they do simply is, they keep on monitoring. They, like, in the start, they ask them to check the glucose level every day upon waking up before breakfast. Okay, then 2 hours after every meal, and like just keep on monitoring. Someone who have high level of sugar, even after giving insulin at the breakfast. So what we do is, like, we increase the bedtime basal insulin, of course, so that it should work more and cover the morning. Someone who have a high lunch sugar, for example. So what we can do, we can increase the morning insulin last, what you can say, like this way. Okay, that's how they control that. Okay, I hope like you understand this thing, and there is like a lot discussion about this thing given in the slide, of course. Uh, if you are interested, of course, you can go through that. Okay, knowledge is always power. A mixing of insulin is important. Clear is always fast acting before the cloudy are long acting. Okay, to prevent contamination, a short acting insulin with a long acting insulin. Of course, like these are the colors they're talking about. So nowadays, um, insulin pumps are also available. Subcutaneous insulin in pumps are also available. Of course, like they are battery operated, and they they provide a continuous dose of rapid acting insulin, all over the day, simply. And at the meal times, the patient, there is a button on that. The patient can press that button, and it will just going to deliver you insulin bolus simply. Okay, to cover that thing during the lunchtime. So, like, this is all about like the slides. Like, if you don't have the slides, what you can do, you can pause this thing and read. But like in pharmacology books, everything is given. Okay, so I think that's all about the complications. Sorry, treatment. And what is left is complications. And regarding complications, I think what we can do is we can do complication in the next lecture. Okay, so we are going to discuss complications in the next lecture, both the acute complications as well as the chronic complications, and we are going to cover all the topic in that one. Okay, so next lecture will be about that complications thing. So I hope you learn about the diabetes treatment. It's not so hard to remember. Okay, so see you in the next lecture.